Good morning, everyone. Welcome to the PT on Ice Daily Show, brought to you by the Institute of Clinical Excellence. Happy Wednesday. Today is Jerry Ano. I am a TA within the Modern Management of the Older Adult Division in both the live and online settings with lead faculty Dustin Jones and Christina Previtt. Modern Management of the Older Adult the Online Essential Foundations begins August 18th. You can catch us live all over the United States at the end of August into the new year. So make sure you go to ptonice.com to check out more. On to today's topic, nutrition and the older adult. To set you up perfectly for this conversation, I would like to point you back to Alan's podcast, number 979, on June 18th, to get a better understanding of why clinicians should and can be screening our patients' nutrition. He described some great examples that resonated with me quite a bit, and it really described well what I was seeing with older adults that I treat. Though I think there are some caveats to how we prescribe protein and calories, etc., to the older adult, and what we talked, understanding that the barriers are going to be a little bit different than the younger patient. I will also be highlighting the ways that occupational and speech therapy play a large role in this conversation too. First, I recognize and honor that dietitians are the complete experts in this space. Literally, they're the ones who can prescribe diets and monitor changes with the diet when somebody is in a disease state, which is a lot of people who are older. I will mostly be talking today about screening nutrition and just getting an idea if our patients are eating enough, what to look for when we're screening nutrition, and when we need to refer out to a dietitian or get occupational therapy and speech therapy counterparts in to help us. Now, Alan mentioned this, but dietitians are really hard to find in an outpatient setting, in the outpatient world. And a lot of our clients will struggle finding access to one. And if someone is barely eating or isn't eating enough protein, this is going to impact their gains with physical therapy, and we have a role to play in providing these general guidelines for nutrition. Let's talk about aging for a moment. As people age, they do have decreased appetite due to decreased their number of taste buds also decrease. So you're working with those two things there, which is going to decrease overall levels of food intake, and therefore decrease micronutrients as well, so like calcium, iron, vitamin B, zinc, etc. Daily volume of beverages will also decline due to a decreased thirst sensation. So in this population, we're working with people who have less of an appetite, also have less thirst sensation. So it's not as easy as saying you just need to eat more and eat more protein, right? Because that may not work just due to the natural issue of aging. So what I'm seeing most often when treating older adults is a total lack in caloric intake and poor protein intake. Those are the two main things. A lot of my patients unknowingly subscribe to intermittent fasting because they're just having like a cup of coffee for breakfast and not really eating until afternoon or later. Now, intermittent fasting totally has benefits for certain parts of the population, especially with older women. But if somebody isn't eating enough during their eating window, so the time in which they're eating, then they're going to experience this very general decrease in overall caloric intake. Like intermittent fasting is a diet. That's exactly what it's supposed to be doing. However, the problem is when we start asking our patients to move more and be active and they're not really eating enough in their eating window, we run the risk of burning way more calories than they're taking in and really plunging somebody into an energy deficit. Might be okay for some, but if we notice our patients have low energy, they report napping a lot, they're sleeping a lot. Maybe they're dizzy, they're lightheaded, they're having like hypoglycemia. Maybe they're in a lot of pain, right? They've had pain for a long time. Maybe they're losing weight without even trying. Then maybe we're doing more harm than good by not screening for nutrition. So that's why with almost all of my patients, we will talk about food. We will talk about the hours of extra exercise now they're going to get a week because they're participating in PT with me. And I'm asking them to increase their overall energy expenditure because I'm trying to promote like increase in activity when I'm not there. So I'm asking them to be extra active. Now, a big thing I'm finding lately is people under fueling, especially when they have multiple disciplines in. So I'm finding a lot of my patients who start seeing PT and OT. So when we add in the OT factor, or when I jump in on a case that OT is already on, the patient is now getting like 4 or more hours of exercise that they weren't getting before, on top of a diet that was barely providing them the adequate energy they need. Can you see where this would become a problem? My priorities when it comes to screening nutrition are 4-part, okay? 4-part. First, I need to know, are they eating enough calories? This is a reminder to everyone out there. This is my favorite fun fact. 1,200 calories is the amount a toddler needs to stay alive. A toddler. Older adults are not toddlers, so they need to eat more than 1,200 calories a day. It is very common when I ask my patients to do a 1 to 3 day food log that they are eating less than 1,000 calories. Very common. Alan described in a case and example like that as well. No wonder they are tired. No wonder they are losing weight, they're losing muscle mass, and they're still in pain, or they're getting weaker and weaker, right? If I plan to do moderate to high intensity exercise with them and they aren't eating enough, they're not going to feel great. Think about a day that you barely ate anything and then popped into the gym later and you were like feeling just so sluggish and like underfueled. Like, that's how our patients are living. Second, are they eating enough protein? As someone ages, it is recommended that in order to maintain and regain lean body mass and function, they need an average of at least 1 to 1.2 grams of protein per kilogram of body weight per day. Okay, so for example, a 220-pound male will need about 100 to 120 grams of protein per day. Again, it's not uncommon that most of my patients are eating less than 50 grams of protein a day, especially no protein in the morning. Like, most people are eating, like in their 80s, are eating like a warm cereal or a kashi, like bowl of cereal that they've been told has high protein, but it has like 6 grams. This is a behavior that I try to change and encourage people, or just give them the education that there's different things that you can eat for breakfast that has protein in it. I would like you to try to eat protein with every meal. I will go over a nutrition label with them just so they can see, okay, this is why peanut butter is maybe not the best protein source that you can eat. Maybe it's an okay protein source, but maybe there's better. I go over the nutrition label with their Ensure, right? Ensure, the regular Ensure has about 9 grams of protein in it. 9. I tell them like 9, okay, you need 70. Like, is 9 gonna be a good amount to get you there? Maybe not. We talk about making simple swaps. For example, Dave's Killer Bread has protein in it versus a regular white bread. Maybe they can eat turkey bacon and eggs in the morning, or they can use Greek yogurt instead of their regular yogurt. More often than not, a lot of my patients end up buying like a jug of protein powder, right? I've walked into a few houses that have Optimum Nutrition protein in them now, and they're making shakes instead of the typical Ensure or Boost. Now, this is again where we need to be careful, because somebody with chronic kidney disease may not benefit from a significant supplementation of protein. This is why it's really important that we refer to the RDs. This is why we can't make blind recommendations without really understanding disease states. So I understand that with chronic kidney disease, protein intake and protein, the usage of protein may be difficult for kidneys that aren't working great. So I need to be aware of that and say, you know what, I might not know the optimal amount for you, but you would probably benefit from an RD to make these recommendations. Again, I can provide the basics of what I know, but I can't totally change their diet, etc., because I'm not going to be monitoring those changes. Third, I like to make sure people are taking in enough liquids. Hydration is a big thing. You wouldn't believe how many dizzy patients feel a lot better once they're drinking enough water. You can prevent a lot of UTIs this way as well. If you're a Jerry PT, you know UTI can really mess up a plan of care for a few weeks. You want to prevent those. I've seen the recommendation before of like 1 cup of water to 20 pounds of body weight, so that could be a general recommendation you use. Now, there are easy ways to encourage water or fluid intake. My favorite way to get water started early in the morning is I find a lot of people reach for the cup of coffee first. Fill up the coffee cup that you will use for your coffee with water first, so you need to drink it. Then you can fill it up with coffee. That's a tip from the Sassy Dietitian if you follow her. You can also recommend eating more water-filled fruits and vegetables. Watermelon is perfect this time of year, cucumbers, etc. For people who struggle with water because it just doesn't taste good, you can recommend foods with water. You can also recommend for people with dementia or who have trouble just remembering to drink water in general, just keeping a water glass next to them and offering water often throughout the day is important. Lastly, recognize that a person may not just need to be flooded with water, but instead may need electrolytes with their water. I choose liquid IV myself to keep myself actually hydrated versus just pounding gallons and gallons of water all day. Now, be aware that some patients will be on fluid restrictions. Again, this is where we just need to be smart about our recommendations. Some patients will be on fluid restriction, heart failure, for example. This is when we need to be smart about it, understand those fluid restrictions, and understand what we're going to be asking our patients to do. Lastly, and most importantly, have your head on a swivel ready to refer to PT or OT and speech. As the PT, I can give basic advice. I can give them the recommended guidelines, and that's about it. I can't bill my time for like walking them around their kitchen, going through all their food options, reading nutrition labels, talking about how to plan a meal, or I can't do that. But you know who can? Whose bread and butter that is? Occupational therapy, right? I understand that like my patients totally may get that they need to take in more protein, and I might try to follow up with them like, oh, how's that going, etc. And I really do try to follow up on things like that, but it might not be like a lack of understanding, but rather they physically can't make protein-filled meals or eat a lot because there are safety concerns during food preparation, right? There are fall risk in the kitchen. There's a lack of accessibility to food. They can't get the food that they need. There's a decreased ability to read a food label. Maybe there's vision issues on board. Maybe they've just never been taught. There's an inability to effectively plan meals and grocery shop. Meal planning is a big cognitive task, and if somebody does not have that capacity, my recommendation for protein intake may just go right over their heads and we might not get anywhere. OT is literally, this has a huge role to play here, and it's like in their job description. Once I know somebody's having issues with nutritional intake, I will lean on my OT counterpart to help me figure that out, right? Maybe they need help with motivation and tracking changes and using things like MyFitnessPal or just pen and paper and learning about how to track diet changes, which OT can do. Can they work on preparing meals together? Absolutely. Can OT teach somebody how to meal plan and literally go, my OTs at Fox can go to grocery stores, meet a patient at a grocery store and do the grocery store with them, looking for different foods, right? Scanning the environment, finding the right things, so it's not this big effortful task. Or OT and PT a little bit, but more OT can look for community resources to help patients who might not be able to do these things, right? Is this a Meals on Wheels situation? Does this person just need more consistent food, like a more regular and consistent food source? Meals on Wheels is perfect, right? Maybe you can use other meal services in the area. Those awesome meals that you pick up from the CrossFit gym can work really well for older adults. They are not exclusive to you. I personally get a lot of my patients to order Mighty Meals, which is the meal service like in this area. They get dropped off at my door once a week. They work perfectly. So look up those meal prep services in the area because they can be an awesome tool and resource for patients. And like most of the time, one meal ends up being kind of two for them because they're not used to eating that volume of food. So it kind of works out cost-wise as well. The work will continue for OT if nutritional problems are from poor posture when eating, right? They're having trouble with positioning. Maybe this person needs adaptive equipment while eating, scheduling meals, and educating the caregivers on how to implement all these changes. If somebody has a serious tremor and I'm over here asking them to slam a chicken breast because that's what they gathered from my protein conversation, it may not actually happen. And it's not because they don't want to be compliant. Rather, they can't physically cut and manage to eat that type of food. Speech therapy will also be a huge resource in this space when issues of swallowing come into play. People might do great with a protein shake, or people might need a thicker option, right? The Ensure Boost may be better. Or maybe the person would do better with a thinner option. So like a regular standard protein shake may work. I don't have the skills to assess that. And sometimes I need to lean on my speech therapy counterparts for that information. They also may be able to provide a better insight in like recommendation for protein. So maybe somebody would do awesome with ground beef covered in some kind of sauce, like that may be easier to swallow. than, say, like a cooked chicken breast. Large chunks of chicken may not float well in someone's throat. So again, these are things that my counterparts can do a really good job, and we can actually make these treatments really effective for our patients. Like, I can only tell them to do these things, but OT and ST can make them happen. I hoped this helped get your wheels turning about nutrition and hydration for older adults. I hope it highlighted that there's like a lot of space for referral here, and our role is screening and giving general recommendations so that our patients can get the most from our sessions. We don't want to leave anything on the table. We don't have the time to. I would love to hear your thoughts below and how you implement some of these things, how you use OT and speech. And yeah, just please comment away. I would really like to get this discussion going. Have a great Wednesday.